All right, good evening and welcome to our second mini-med school session for the semester. My name is Franza Balaga and I am the programs manager for Colorado Area Health Education Center. And we're very excited to have you all here. So we're very excited this evening to welcome Dr. Ariana Nestler. Originally from West Hartford, Connecticut, Dr. Nestler received her medical degree from Tufts University School of Medicine in Boston. She then went on to complete her residency in family medicine at the University of Colorado in Denver Health Track, where she was the chief resident in her final year. She's currently a faculty development fellow in the Department of Family Medicine at Denver Health, practicing both inpatient and outpatient medicine with a focus on medical education at the medical and resident level. She loves full spectrum outpatient care, including prenatal care, refugee health, outpatient procedures, gender affirming care, and addiction medicine. Outside of clinical work, she is deeply passionate about teaching the next generation of physicians with a hope to expose learners to primary care and family medicine early on their training. Beyond medicine, she loves hiking in the mountains with her husband, trying new restaurants and coffee shops, and spending time with her nieces and nephews. Welcome, Dr. Nestler, and thank you for presenting tonight. She will be presenting on the menstrual cycle and contraception, IUDs, implants, pills, oh my. Thank you. Thank you.
All right,
Over.
thank you.
Good.
Perfect. All right. Hello, everyone. So as she mentioned, my name is Ariana Nestler. I am a family medicine physician, and I'm currently practicing at Denver Health. I am a faculty development fellow, which means part of my time is spent primarily focused on medical education. And I'm really excited to be with you today to talk about the menstrual cycle and contraception, and we'll get into it. I will pause briefly during my presentation for questions and probably take one from the audience here and then one from Zoom, hopefully, if that works. And we have some changes in technology and things like that, so bear with me. All right, can we move the bar? Yeah. Cool. Okay, so my objectives today will be to review and describe the basic physiology of the menstrual cycle, relate the menstrual cycle to birth control options, and describe the various birth control options and apply knowledge to patient cases. As a caveat, I am not a pathophysiologist. I'm not an expert in histopathology or anything like that. What I really want us to understand together tonight is just the basic physiology of how the menstrual cycle works and how we can apply that to birth control and why birth control works. So that's really my goal of this talk today. There's lots of other hormonal signaling pathways and neuroendocrine pathways that I won't dive deep into, but we're going to talk about some of the major players here. All right, before we start, I want to kind of get a sense of who's in the room. So I want everyone to either scan this QR code, I hope it works, or log into Poll Everywhere. So you can type in the URL polleverywhere.com/honestocean779, or you can text honestocean779 to 37607. It might ask you to register, you can skip it. It might say, log in with your name. You can skip it, keep it anonymous. And we'll answer this question. And let me see if I can pull this. Amazing. Oh, where'd that go? Looks like it's working here. I just can't full screen it. All right. Trying my Mac over here. Can I do that? Haha. Nice. Yes. Yes. No, you're fine. You can also text Honest Ocean 779 and you text it to the number 37607. How are people doing? Good? No, not good. It says pollev.com/honest-ocean-779. Yep. But now I can't. Here we go. Okay. For sake of time, this is what we have here. There'll be some more questions, so keep this open or up as we go along here. Thank you for the technologic support, Fran. All right, so we have a variety. Most people have learned about it several times, some never, some so many times they can't keep count. If you're like me, I've learned this so many times, and every time I learn it, I forget it and have to relearn it. So that's what we're going to do today. And we're going to go very, very slow. Okay. Let me see if I can pull this PowerPoint back up. Yes. Does it still work? Amazing. Okay. So before we start talking about the menstrual cycle, we have to all be on the same page about what the anatomy looks like here. So anyone that has a menstrual cycle has a uterus. The uterus is connected to the fallopian tubes and the ovaries. The ovaries are what house our eggs. Anytime someone is born with ovaries, they are born with all of their eggs or oocytes that they will have in their lifetime, but these are in a premature form. So over time, these will mature various times in the human life cycle. And then you have your cervix, which is the opening to the uterus, and then the vagina. I want to have everyone take a look at this bottom right screen here, and I'll try to point on the, if you can, oh, maybe you can't see my arrow. Point over here. So here is the uterus, bladder connected to the urethral opening here, uterus connecting to the vaginal opening, and you have your rectum connected to your anus. Okay, and so see how the uterus is kind of tilted forward. In most folks, this is the anteverted position. This is what what we typically see. Some individuals have a uterus that's kind of tilted on its side with the top facing backwards. Normal, nothing wrong with it, just different. And some people somewhere in between. And that'll become relevant as we kind of move forward here. I want you to all pay attention to the lining of the uterus. So the endometrium, the uterus is made up of 3 layers: the serosa, which is the outermost layer, the smooth muscle, which is the myometrium, and then the endometrium. We're going to talk a lot about the endometrium. All right. Before we can talk about the menstrual cycle, we need to talk about biological feedback loops. And the way we talk about positive and negative feedback loops. And so in everyday life, I hope we've all received positive feedback at some point in time. So you're doing something, someone tells you you're doing it well, you do it more and more often, right? So same thing in human biology. So let's say this is a cell, a square that's producing these dots. If the dots tell the square positive feedback, tells the square do more, the square will produce more dots. Positive feedback, pretty simple. Negative feedback, similarly, if you have a square producing these dots and the circle says, stop producing these dots or turn off your dots, that's a sign of negative feedback, okay? I have a picture of a thermostat here, which is set to 78 degrees. I don't understand that. Don't know why anyone would set their thermostat to 78 degrees. But if you set your thermostat to 78 degrees, your heat will blow until it reaches 78 degrees. And then the heat itself will turn off the heater, right? So that's a negative feedback system in our everyday life. Same thing in human biology. Okay, with me so far? All right, back on Poll Everywhere. I want everyone to click in to how many days is the average menstrual cycle. Aha. Oh, I have to. How do I get it back? Come help me. Because now it's in full screen and I can't drag it. I have to activate it for them. Okay. I have to go back. Let me just drag it. All right, it should be there now. Yes, great. If this has popped up. Cool, thank you. All right. Give you a couple more minutes here. The QR code is still here if you need to scan it, or the instructions up here. All right. So the correct answer here, and I'm just going to move this off the screen again, is actually 24 to 38 days. So lots of variability between individuals. And that's what's considered normal by medical terms. What we're going to use today is the magic number 28 because it's easier to deal with and easier for us to kind of talk about the cycle here, okay? Before we can talk about the menstrual cycle, we also have to talk about some other major players. So the mastermind of everything, the brain. And this is a blown up picture here of your hypothalamus, which sits inside the brain and talks to the posterior and anterior pituitary. We're going to ignore the posterior pituitary today. The anterior pituitary produces hormones, follicle stimulating hormone and luteinizing hormone, that are really important in the menstrual cycle and talk to our uterus and our ovary. And our ovary produces estrogen and progesterone. So these are our main players that we're going to talk about. All right, this is the menstrual cycle. Looks really complicated and there's a lot going on here. We're going to walk through it very slowly. What I want us to pay attention to here is that it's split into two phases, the follicular phase and the luteal phase. And as you can see on the bottom, oh, what happened? Oh, okay. On the bottom, 28-day cycle, starting with menstruation, moving into a proliferative phase, ovulation, and then a secretory phase. I'm going to talk about what happens in the ovary and what happens in the endometrium, the lining of the uterus, okay? Okay, we're going to start here, which is like mid to late follicular phase. And so what happens here is a couple things. So your hypothalamus, remember that structure in the brain that I talked about, pulses throughout, after puberty, it starts pulsating, and it'll increase its pulse frequency around this time. And it stimulates FSH and LH, so follicle stimulating hormone and luteinizing hormone. The follicle stimulating hormone in particular causes follicles to grow. Now, follicles are in the ovary, and they are fluid-filled sacs that contain your oocyte or your egg, okay? And so over time, these follicles themselves produce estrogen. So I'm going to show you here. This light blue line is the FSH. So stimulated by GnRH, or gonadotropin-releasing hormone, FSH will slowly start to rise, and follicles will start to be stimulated and grow. They'll produce estrogen, this pink line here, and that estrogen will continue to rise. Now, the estrogen itself will at some point become a negative feedback system inhibiting FSH and LH. So you'll see here, oh, I did it again. Okay, there we go. You'll see here that estrogen, as it continues to grow, will suppress FSH and LH down here. Now, not all follicles will be able to continue to grow as FSH is lower. So as there's no more stimulating hormone, a lot of the follicles will die off. In fact, all of them will die off except for one dominant follicle. Okay? That dominant follicle will continue to secrete estrogen. So you see this estrogen rise as the dominant follicle grows until at some point that negative feedback will switch to positive feedback. And in the science and medical literature, we still don't quite know exactly how that switch happens, but it does. And it causes a surge of LH, the purple, and FSH, the blue, to rise. So essentially, the dominant follicle will secrete estrogen, so much so that at some point, it will become a positive feedback, causing the pituitary to release more FSH and LH. Now, that happens 1 to 2 days before ovulation. So that's kind of how we know ovulation is about to happen. We have what's called the LH surge. All right. What's next? So that's what's happening in the ovary. So what's happening in the endometrium during that time, or the lining of the uterus? So the beginning of the cycle, like I mentioned, is the shedding of the lining of the uterus, or the menses is the medical term for a period. And after menses becomes the proliferative phase, which is stimulated by the rising levels of estradiol from that dominant follicle. So as estrogen continues to grow, not only do you have your follicular growth, but you also have this thickening of the endometrium. You have an increase in the glands and spiral arteries, which feed the endometrium, and cervical mucus becomes more hospitable to sperm. Okay, so we have the rise in estradiol, we have the growth of the dominant follicle, we have the thickening of the endometrium up until the point of that LH and FSH surge, and then we have ovulation. So ovulation is the rupturing of one of that dominant follicle to release the oocyte into the fallopian tube. Okay. This usually happens around day 14. Now that can vary. The follicular phase varies between individuals. What we'll talk about next, the luteal phase, is pretty consistent in terms of its length of time. But let's call it 14 days because this is a 28-day cycle is when ovulation happens. All right, we're in the luteal phase now. So we just had ovulation right here, and the follicle was released. And what happens is the remnant of that dominant follicle that's in the ovary becomes something called the corpus luteum. The corpus luteum secretes progesterone. Now, it's a little bit more complicated in that the lower levels of LH, because they decrease after that LH surge, converts cholesterol into precursors to progesterone. So I didn't mention earlier, but progesterone and estrogen are steroid hormones, which means they derive from cholesterol. And so during this time period, there's a conversion of cholesterol into progesterone, which is released from the corpus luteum. Okay, and progesterone, so that's, progesterone is your green. So over time, this rise is coming up. This is estradiol, the pink, so still a high-ish level, but predominantly progesterone dominated in this phase of the cycle. And it's suppressing LH and FSH, so acting as negative feedback during this time of the cycle. In the endometrium during this time period, you'll have what's called the secretory phase. So the endometrium, what happens is you have the spiral arteries start to coil, the uterine glands secrete more mucus, but after really around day 15, the cervical mucus will thicken because of that progesterone, and it'll become less hospitable to sperm. So unless fertilization happens, less likely to happen as the luteal phase moves on because of all of these changes. And eventually that corpus luteum that we saw will be triggered if there's no fertilization to regress into something called the corpus albicans, which is inactive. It doesn't secrete hormones. And that decrease in progesterone and estrogen triggers the endometrium to shed its lining, and you have a menses. So we're back here. So just for review, oh, I keep mixing my lighter and my forward button. Okay. Progesterone increases from the corpus luteum. The secretory phase happens here. The corpus luteum basically regresses into the corpus albicans, no longer secreting progesterone. That triggers a withdrawal bleed, and we move back to the beginning of the menstrual cycle. All right. I want to pause here. Questions about the menstrual cycle. That was a lot of information. I'll take one if there's one from the audience, and then one from the chat if there's someone from the chat. She might come with the mic, or someone might come with the mic. Perfect.
So the non-dominant follicles?
Yes,
What happens to them?
great question. Most of them will die off in each cycle. So you'll lose follicles that are dying off essentially within each cycle. You have lots and lots of follicles that mature at different rates within the ovaries. And so in each cycle, you will lose some of your follicles. Yep. Yeah. Yeah. Other
C, I have one from the
Yeah.
chat.
Yeah.
What is the difference between progesterone and progestin?
Great question. We are going to get into that in more detail. The question was, what's the difference between progesterone and progestin? Progesterone is what your body produces itself. Progestin is the synthetic form of progesterone. So what's in our birth control options? Great question. Okay. If we can log on to Poll Everywhere. The next question will be, which contraceptive method is the best? Good question. Yeah. So lots of different responses here. We have some, about a third, say IUDs. We have 10% saying the implant or the brand name of Nexplanon, birth control pills. Some people think condoms. About a third say none of the above. We had a good question in the audience here. What do you mean? What are we talking about? And this was kind of a trick question because there is no best. If you ask me which one's the most effective, then we're going to have a different conversation. But if we're talking about which one is the best, it's really what's best for the patient and what they want, what their medical history is, what their desires are. All right. I'm getting better at this. Cool. All right, but how does it work? So I like to break it down into hormonal and non-hormonal options. You'll see a lot of posters break it down in, effectiveness, middle of the road, least effective. I find this helpful because I think a lot of folks are wondering, the main question is, I don't want hormones or I do want hormones. That's typically what I hear a lot. And so we're going to talk about each one of these. This is an example of a pill pack if you haven't seen one before for oral contraceptives. This is an IUD. This is pretty much to scale. That's how small they are. And then non-hormonal options, we'll talk about some, not all, because there's more and more things that are coming out in terms of non-hormonal options. Those are condoms. This is a copper IUD, or the brand name of a Paragard, which doesn't have hormones in it. And we're going to break it down even further. So hormonal options, there's the combined. And when I say combined, I mean they contain estrogen and progesterone. The combined options are pills, patches, or vaginal rings. And then the non-hormonal options, like I mentioned, the copper IUD or the brand name Paragard, condoms, both internal and external condoms, diaphragm, fertility awareness, meaning someone who is tracking their cycle. Now, we talked about how cervical mucus changes throughout the cycle. That's one way to track when your LH surge is happening, when you're ovulating. The other thing that we didn't quite get into is temperatures do change throughout the menstrual cycle. So some people will monitor their temperature as well. And then sterilization procedures are tubal ligation or partner vasectomy. There are others, there's gels, spermicide, things like that. These are just a few of them. Okay, the combined methods. So the estrogen component is usually ethinyl estradiol in the combined pills, patches, or rings. And then the way they work is the estrogen and progestin together suppress LH and FSH, so they prevent ovulation. Because right, it's similar to what we saw in the luteal phase, where the estrogen and progesterone levels are high and you're not having ovulation. Those FSH and LH levels are low. Some people, for the placebo pills, so basically in a pill pack, or if you take out your vaginal ring, or if you take off your patch, you'll have a sharp decrease in your hormones, causing that withdrawal bleed. Similarly to what happens in the menstrual cycle, right? So when you take away those hormones, you have menses. So that's what happens here. Some people choose to use their pills or their patches or their rings continuously, and that's okay. They don't need to take a placebo week. They do need to switch out their ring because it only lasts for a certain amount of time. So they need to change it, but they can just put a new one in. And the reason is because they're not having that growth that's from the estrogen component, that increase in estrogen. They're not having that proliferative phase that can lead to increased cell turnover, can lead to precancerous states and things like that. So it's okay to continue on through your pills, your patches, your rings. Combined methods, a caveat here is that there are contraindications to estrogen. So not everyone should or could take estrogen. And the main reason is because we know at higher doses of estrogen, there's a little bit of an increased risk of blood clots. And since we have more options, it's safer to try some of the other options rather than these. So these are kind of the three I talk to my patients about. One, have you ever had a blood clot or venous thromboembolism? Or do you have a condition that puts you at risk for a thrombotic state? So cirrhosis is one of them, some malignancies. Do you have a migraine with aura? Most people don't have aura. It's a specific kind of light alteration prior to migraines typically. Or do you smoke cigarettes? Usually the real contraindication is greater than 15 cigarettes a day and you're over 35. And that's because we know cigarette smoking increases your risk of clotting as well, as does estradiol therapy. So these are kind of the big three that I always ask patients about. Progesterone-only methods. So comes in pills, injections, implants, and IUDs. These don't always suppress ovulation. So the mainstay of how these work is really that thickening of the cervical mucus that we saw happened in that luteal phase. Some of them slow down the transition of the egg through the fallopian tube as well. They thin the lining of the endometrium, and then IUDs themselves also create an inflammatory response, which has spermicidal effects and inhibits fertilization and implantation. All right. I want to just put this up there to kind of go through some of the main types of progestin only, because beyond the combined methods, these are the ones that I see prescribed or asked for the most. So POPs are progesterone only pills. So they're like the combined pills, but they only have progestin. They're about, you'll see, oh, I changed this. Oops, okay. Well, this number should be more like 91 to 93, but really it's difficult to say because if you're using them perfectly, they're probably 98% effective. If you're using them imperfectly, which most people do, meaning they're not taking exactly the same time every single day, 91 to 93%. Sorry, I don't know why I wrote 95. And then main side effect would be irregular bleeding, the implant or the Nexplanon. So it lasts, last 3 years. There's some data that's showing that it can last for 4 to 5 years. So some institutions are moving towards that. Mine in particular is not, so we still recommend it getting changed for 3 years. So it depends who your providers are and how they interpret the data, really. It's 99.9% effective. For the most part, 99, yeah, because it sits in your arm and you don't have to do anything. It just does its job. Most common side effect is irregular bleeding. And then you have IUDs, which have lots of different brand names, and they all last for a different amount of time, depending on how much hormone is in them. So you have the Skyla, which has the least amount of hormone, and it lasts for 3 years. You have the Kylena, which has a little bit more, I believe, and it's lasts for 5 years. And then you have the Liletta and the Mirena, which are exactly the same, more or less. They have the same amount of hormone. They are just 2 different brand names, and they're now FDA approved for 8 years. And then the Paragard is the last option. So that's, again, a copper IUD, does not have hormone in it. And it's FDA approved for 10 years, but there's studies that show it can last to 12. So again, some people will tell you it lasts for 12 years based on the literature. 99.9% effective. Cramping and bleeding with the insertion is the most common side effect. And then Paragards themselves can cause some heavier menses or cramping with menses. Last one I want to talk about is the progestin injection. So that's a Depo-Provera is the brand name. You have to get it every 3 months. And this one, I believe I meant to write, I think it's like 94 to 95%. It depends. People will say different things. And again, it's because how often are you coming in that exact time frame every 3 months? Because if you miss it, chances are you could get pregnant during that time period. Irregular bleeding and increased appetite. Okay. So the last kind of section I want to go through here is talking about the procedures that can happen with birth control. So we talked about pills and patches and rings. Those are user-friendly. Anyone can do them. To put in the implant or the IUD, you have to go see a doctor or a clinician. And so for the implant itself, what happens is you will have your patient lying down with their arm flexed at 90 degrees like this. And you will measure 10 centimeters from the medial epicondyle of the olecranon, which is a fancy way of saying the middle side of your elbow. And so I usually measure about like 4 finger breadths is usually around 10 centimeters. So measuring from here to here. And then you measure 3 to 5 centimeters beneath your bicipital groove. So if you all can feel on yourself, you have a bicep and you have a tricep. And in between, there's this kind of groove. That's where all your nerves and arteries are running down your arm. So we don't want to be anywhere near that. So we go 3 to 5 centimeters beneath it, or 2 to 3 finger breadths. And that's where we insert the device. First, we would clean and anesthetize the skin, and then we would insert the device with an insertion device. And we close that area because it'll leave a little bit of a bigger hole because it's a little bit of a larger needle. With steri strips, which are just like clear plastic strips that fall off on their own. We put gauze on it and we wrap it with a pressure dressing to help with bruising. The removal can be a little bit more challenging in that over time, the implant would develop typically a fibrous capsule around it because that's what your body does when it sees foreign things. It develops kind of this protection around it. And so similarly, you'll place your patient in this position. And what your provider will do is clean the skin, anesthetize it, take a scalpel and make a small, very, very small incision at what's called the distal end, so closer to the hand, make a hole with the scalpel, and then sort of cut away at the fibrous tissue until it becomes loose enough that it just kind of pops right out of your arm. So I always tell patients the removal can take longer than the insertion, because the insertion is just right in with the device. The removal, we have to kind of break down some of that tissue. Now you're inserting this device subdermally, so you can feel it. It's just right beneath your skin. It doesn't go into the muscle itself by any means. Okay, that's the implant. And the brand name is Nexplanon. I've seen tons of commercials for it these days, so you've probably seen it. It says, ask your provider about the Nexplanon. That's what they're talking about. Okay, IUDs, insertions, and removals. So the insertion, you again have to go to a clinician's office to get it inserted. You place the patient in dorsal lithotomy. So dorsal lithotomy is the proper way to say, lying down on the table with feet in stirrups, like you would see in a gynecologist's office or someone giving birth. That's dorsal lithotomy. And then the clinician will usually do a bimanual exam. So they'll do an exam where they put 2 fingers inside the vagina and 1 on the abdomen. And that's to feel the position of the uterus and the cervix. Because remember, I talked to you all about how the uterus can point forward, it can point backwards, but it's really hard to insert an IUD when the uterus is like this, right? So the way that helps the insertion is by straightening that out a little bit. And I'll tell you kind of how we do that. but we need to know which position it's in order to figure out which way we need to go. So after the bimanual exam, the clinician will insert the speculum, which is the same device used for pap smears, if you're familiar with that. They'll clean the cervix, usually with an iodine or chlorhexidine solution, and then they'll place the tenaculum. So the tenaculum is what's placed on the cervix itself, and it helps pull the uterus a little bit into place so that it's easier to place the IUD. They will then sound the uterus. So they take a rod that has different measurements on it and will go through the cervix until they hit the top of the uterus and take it out and see what that measurement is. Usually it's around 6 to 7 centimeters. So actually not that big, maybe the size of your fist is kind of the length from the cervix to the top of the uterus in a non-pregnant person. And then they'll match the sound, so whatever that measurement was, to the insertion device of the IUD and insert the IUD. They'll cut the strings and the procedure is done. It doesn't take as long as how I just explained it. It's usually 10 minutes, 15 minutes. The removal's actually quite easy. Same thing, same position, inserting the speculum. You'll see the strings, hopefully, around the opening to the cervix, which is called the os. And you'll grab it with ring forceps, which are basically like long tweezers that have circles kind of on the end. You'll grab the cervix and you'll pull, and that's it. And the IUD should come out intact. Okay. So we talked about the menstrual cycle. We talked about the follicular phase. We talked about the luteal phase. We talked about what happens to the ovary and the eggs inside. And we talked about what happens to the endometrium during that time period. We talked about implants. That's a picture pretty much to scale. I might not put it so close to the armpit there, but that's pretty much to scale. We talked about IUDs. We talked about pills. We talked about other forms of contraception. Now, I want us to think back and remember, this is not on Poll Everywhere, but if someone wants to shout it out, how many days is the average menstrual cycle? 28, but there's the range 24 to 38, right? So people can vary, but 28 is what we usually use to kind of have a best guess. Cool. Which contraceptive method is the best? It depends. Amazing. You guys are listening. All right. Before we go into some cases that we're going to apply some of our knowledge, I want to just see if anybody has one from the audience and maybe one from chat, and then we'll do some open questions after. Any questions about that contraception in general? All right.
See, I do have one from the chat.
Yeah.
How does heredity from the mother or grandmother affect what type of birth control one chooses? For example, this person's mother had PEs.
Yeah, so great question. So if I had a patient that said my mom had PEs, which are pulmonary embolisms or blood clots in the lungs, I would probably counsel them on, your risk might be increased. If their parent knew that they had a genetic predisposition to blood clotting, so some type of clotting disorder, then I would either advise the patient, we could test you, or we could say, there's so many other options. Why don't we try one of these other options first that don't contain estrogen in them, right? Because the estrogen are just the pills, patches, and rings, and there's a whole lot of other options. So that's probably how I would counsel that person in terms of what's the best choice for them. Any other questions from the room? Yeah.
Okay, kind of extending on that question, if having taken like the pill in the 70s or 80s, could have that caused a clotting issue later on in life after you stopped taking it?
It's a great question. As far as I know, your risk is only while you're on the medication because the medicine doesn't last that long, is my understanding. But I can't say with 100% certainty, but I believe that, if you stop taking it, because you can get pregnant right away, your cycles return. So I don't think they're related. We have one more.
I have another from the chat.
Okay.
Are teens still prescribed birth control hormones to control heavy bleeding / cramps?
Yeah. So anyone, not just teens, can be prescribed birth control to help with heavy bleeding or cramps. One, because the progesterone component is going to thin the endometrium, so you'll have less heavy periods. And so that's the mainstay of how that works. And you also have a controlled cycle, right? You know when your period is going to be because you're controlling it with those withdrawal bleeds. So yes, it's one of the mainstays of treatment for heavy menstrual bleeding or irregular bleeding, are some of the hormonal IUDs or birth control pills if you don't have a contraindication to estrogen. Great question. All right, we're going to go to some cases that'll take us to Pull Everywhere for the final time. So our case number one, we have a 26-year-old female who wants to talk about contraception. She doesn't like the idea of something inside her uterus and doesn't think she'd be able to take a daily pill. Which options might you talk to her about? Now, these are not all encompassing, but of these options, which might you talk to her about? And I have to activate it, so give me 1 second. Oh. All right. So nobody said the IUD, which is great, right? She told you she doesn't want anything inside her uterus. So just those options are off the table, right? We don't try to convince people of something they don't want. Patches or rings, implant or injection, or B and C. So the answer here is B and C. So patches or vaginal ring would be a good option. It's not a daily pill, or an implant or progestin injection. You could also talk to her about all the other non-hormonal options, barrier options that we talk about. Great. Dun, dun, dun. Next case. Oh, do I have to click in here? There we go. You have a 37-year-old female who comes to your office wanting to discuss birth control options. Upon further history taking, you discover that she smokes a half a pack per day, that's PPD, and she's afraid of needles. Which options might you talk to her about? A, combined birth control pills, B, IUD or POPs, progestin-only pills, an implant, or progestin injection. And give it another minute or so. All right. So most people chose B. For someone that chose B, tell me why it's not A. She smokes and she's over 35. Yeah, so estrogen essentially is a contraindication in someone that's smoking, like I said, greater than 15 cigarettes a day, they're over 35. Now, could you talk to her about cutting back on her smoking and maybe decreasing her risk if she absolutely wanted a combined oral pill? Maybe. But again, there's so many other options that are safer that I would counsel her strongly against it at this moment in time. So, and then the implant, could she maybe tolerate a procedure just once and then tolerate the removal 3 years later? You could talk to her about it, but she already told you she's afraid of needles, so maybe not the best option. And then certainly the progestin injection, she's coming to get a shot every 3 months, probably not the best option for her. Awesome. All right. Thank you for bearing with me through Pull Everywhere. That is all I have. I do want to put a plug in. I'm not sponsored by this website by any means, but bedsider.org is something that I use with my patients all the time. I use myself. It's really, really awesome to compare birth controls. It shows effectiveness and different side effects. I really, really like it. So I highly recommend checking it out if you have any other questions that we didn't talk about today. And I will open up for additional questions.
C, I have one from the chat. How does endometriosis play in the cycle? With the cycle, is it related?
Yeah, so that's a good question that is a little out of the scope of this talk, but my understanding is that endometriosis is like as kind of misplaced endometrial tissue, and so it can change with your cycle because it's hormone responsive. So that's a basic question or basic answer to a more complicated question.
So when taking the pill where you never have to have a period, how long can you do that? Is that something that's indefinite?
Yeah, it's pretty indefinite. I would say most patients have a period at some point in time, but you can take it in continuously. There's no problem with that. What I've seen a lot of people do is kind of plan when they'd have a period around like a holiday or vacation, an important event. And so just skip it for a couple months. But yes, you can take it continuously.
With the global fertility rates dropping so dramatically, has anybody done any research into whether these kinds of birth control methods are contributing to that?
That is a good question that I don't know the answer to. I will have to look into it.
C, I have another one from the chat. How to use hormone replacement therapy to manage perimenopausal symptoms?
Yeah, so usually around the time of perimenopause, we're talking about still birth control options. And so typically you can kind of continue your pills around them. Hormonal replacement therapy is usually, you can't just have estrogen, right? Because if you just have estrogen, you're going to have that endometrium proliferation. It's called unopposed estrogen. We don't want that. So you have to have some sort of progestin with it. So it's different dosing, but it changes with menopause that you'll use both estrogen and progesterone to kind of help with some of those menopausal symptoms.
So my question kind of is about the same thing.
Yeah.
So if you are on hormone HRT
Yep.
and it's the combined pill, can you expect that if you just take it continuously, will you get a period if you stop? Like if you're on it for 5 years and you're like done, should you expect you're not done?
Like if you are in this perimenopausal window and you're on birth control and then suddenly you stop it.
If you're menopausal technically and you start HRT.
If you're menopausal when you start HRT, then you shouldn't get a period when you stop. Yeah, if I'm thinking about that correctly.
I have another from the chat. Can you use depot if you have a history of DVT?
When you're saying depot, I'm assuming you're referring to Depo-Provera injection. Yes. So again, it's a progestin only pill or an only method. And so I would say, yes, you can use it. There is a CDC chart that I like to use a lot too, that has kind of the relative contraindications. If you've had a blood clot, I believe that Depo-Provera is okay. Sometimes a certain level of progesterone is different in the different methods. So I'd have to look up specifically if the injection is okay, but I believe so. Yeah.
So with an IUD,
Mhm.
when it's removed, can that perchance cause a displacement of endometrial cells,
Mm.
which could contribute to endometriosis in other places?
Good question. I haven't heard that before. I really haven't. You two are stumping me over there. I really haven't heard that. You pull it out through the cervix, and so it's coming out through that tissue. I don't know. Yeah, they might not get into endometriosis, but they might not. They're more contraceptive related.
C, I have a next question from the chat. Do you recommend taking a vitamin B complex
Mhm.
help with the mood swings and other side effects of the pill?
Good question. I think if it works for you, I would say go for it, is usually what I tell folks. Vitamin B12 specifically related to mood, I haven't heard of.
I may be venturing off a path, but if the endometrial cells
Mhm.
are floating around or growing, how does that lead into possibly endometrial cancer?
Yeah. So the real kind of mainstay of endometrial cancer is what we think is this lifetime risk of, right? We have the growing and the shedding of the endometrium. So anywhere that you have a lot of cell turnover like that is where you can see cancer form. And so if you have someone that has thickening of their endometrium, but they don't have the maintenance from the progesterone as often, they don't have as many cycles where they're cycling through that thickening and then shedding, you can have cell turnover, which creates endometrial hyperplasia, so abnormal cells, and that can be a precursor to endometrial cancer.
C, I have another question from the chat. Does the copper IUD have any negative effects on the body?
The most common side effects I hear with the copper IUD is causing heavier bleeding and more crampy bleeding. So I would say those are the biggest negative effects. Now, IUDs are really great because all their effects are really local. You don't have that systemic or full body effect that you get when you take a pill or when you have a patch on you or something like that. The main effects of the IUD really stay in and around the uterus, but cramping and heavier bleeding for sure.
C, I have another one from the chat. Can a blighted ovum develop while on any of the contraceptive methods?
What was the?
Can a blighted ovum develop while on any of the contraceptive methods?
I'm not sure what they mean by that question.
Well, I do have one more question in the chat. If Mirena IUD was inserted 5 years ago and the FDA has approved it for longer use, is it recommended to switch out or is leaving it in okay?
Leaving it in is definitely okay. Some people feel like towards the end, they start to have different symptoms, like maybe they'll get a period again, because most people with the Mirena or Liletta IUD will become amenorrheic, meaning not having a period or have a very light period. So some people will choose to remove it because they want to, because they feel like they want a new one, they want to have less periods again, but it's perfectly okay to keep it in for 8 years.
See, we have a follow-up from the blighted ovum question. The blighted ovum is referring to a gestational sac growing without an embryo. So is that, can that develop while on any of the contraceptive methods?
Don't know the answer to that one.
Guess I'll tweak that one out. How does a blighted ovum begin?
Yeah, I'm not exactly sure what they're like, because a gestational sac is something after there's fertilization. So that's what I'm a little confused about the question. So what do you mean?
Well, I was just trying to tease it out.
Yeah.
Because you hear a lot about blighted ovums. Well, I used to work on
In-
OB.
Oh, interesting. I don't know.
So here's another one.
Yeah.
This was a long time ago when I worked on OB. I'm not a nurse. A lot of our younger women, the teenagers or early 20s, the ones I get teenagers of color would say they don't want the IUD because it makes your hair fall out.
I haven't heard of hair falling out with the IUD in particular. In fact, I would suspect less so because again, it's having localized effects, not systemic effects.
Right. Plus it's good and good hormones.
All right, if we don't have any more questions, do we have any more questions in the chat? We have one more question, so we'll do quickly one more question and then we will close it off and and then we're gonna ask you to complete a post survey before you leave, but let's ask one more question.
C, the question is, why are IUD highly recommended as a birth control for patients with migraines?
Interesting. I would suspect that the reason is because we know that with estrogen therapy, sometimes your migraines will get worse, sometimes they can get better. And so what I'm imagining is that the provider is trying to give a method that's only progestin only. And that would help maybe not stop the migraines, but it's not going to make it worse. So that would be my thought as to where that provider was going with that recommendation.
All right, well, thank
you
you
all.
so much. A big round of applause for Dr. Nestler. Thank you. If you could please take some time to complete your post survey. And then I have a couple of quick post session announcements. Our next session will be Frontiers in Medicine, and it will be April 17. We probably will, I believe the session will be hosted here in campus. The title of the session is Zoonoses, Not a Good Day at the Petting Zoo. And it's going to be presented by Dr. Mark Deutschman. So thank you again, everyone. Thank you, Dr. Nestler. Have a wonderful evening.